I'm speaking today with Associate Professor Richard King, who is Director of Medicine at Monash Health. And we're talking to him today because he's just been appointed as the inaugural Chair of Choosing Wisely Australia, which launches on the 29th of April. Thank you for your time, Professor.
Pleasure.
Good stuff. Tell us a little bit about Choosing Wisely and what we can learn from the American program, which has been going since 2012, I think.
Yeah, 2012, it was an idea of the American Board of Internal Medicine, and they, over the last 3 years, have got somewhere around about 80 special societies and colleges in America to put down 5 things that probably should not be done by doctors in relation to their specialty.
Right, so procedures we're talking about.
No, we're not talking just about procedures, we're talking about various x-rays. For instance, 3 societies, I think it was, recommended that you shouldn't have x-rays of your back done for back pain until you've had it for 6 weeks, or unless there are warning signs, obviously.
Yeah.
But for simple back pain, you shouldn't be x-rayed for 6 weeks. So it's others, the ENT surgeons, 2 of their 5 related to antibiotic regimes for treatment of infections, sinus infections, ear infections. And so it's not just procedures. In fact, procedures were quite a small part of it.
Okay.
If we looked at the numbers of recommendations, I think 29 related to cardiac, 21 to antibiotics, and 15 to pathology, percent of the things. So the special societies and colleges put these forward. They're evidence-based. Not all of them went about them the same way. Some had specialist groups, some had used all the members of their societies, but all of them had evidence-based for each of their recommendations. And then these were published, both in the journals and also to consumers. And an important part of the American program, which we hope to replicate, is to inform consumers so they can not correct their doctors, but to have an intelligent conversation with their doctors, because often you do have to go outside guidelines, but you need to know why you're going outside the guidelines. And
what's the response been from Australian colleges and
Australian
specialist
colleges'
groups?
response has been has been very good. We've had a very good response from the College of Pathologists, who've already put together a list of 10 things on their website, and the College of Physicians convened a meeting of 43 special societies in Sydney about 4 weeks ago, and that came to a successful conclusion, and they're providing some of the smaller special societies with support to allow them to do that, because some of them don't have the secretarial and other supports to be able to bring that together.
Are screening procedures also part of this, like prostate cancer screening and breast cancer?
That depends on the special society. We would hope that as the College of Surgeons comes on board, that they would bring things like the Urological Society of Australia on board, and that prostate screening may be one of their 5 things. It's not up to us to choose for the special societies. It's got to be things that they want to recommend to other doctors and the public as important things.
And what's the next step once those lists have been compiled?
The next step after that is to publicise them, and obviously they need to be publicised at 2 levels. The National NPS have got a very good track record in reaching both general practitioners and reaching the public.
Yep.
And we hope to use their channels, established channels. We have developed a very good relationship with the College of General Practitioners, who will be a major target, but I hope it just won't be general practitioners, because lots of the other parts of the medical profession will be informed by this, particularly areas like the increasing numbers of general physicians, but also other people who are looking to educate themselves in other areas, because they're short, sharp grabs, they're easy to understand, and they're not implying that doctors have a poor attention span in any way, but when most doctors, in fact all doctors, are exposed to an enormous amount of information.
Yes.
And to know that these have been researched by a specialist society in that society's own area of expertise gives greater credibility to the 5 things they're putting forward.
Right. Is this just about cost savings, or are there health benefits as well?
It's not about cost savings.
Okay.
If there are cost savings, then we're all very keen, but cost savings isn't what this is about, and that was emphasised by the American choosing wisely. I think we'd be naive not to think that the insurers aren't going to be interested in the product.
Yeah.
But that's not the aim of it. The aim of it is for patients to get the best from their doctors, and doctors to be as well informed as they can be.
Terrific.
And it's an easy way. I've read about 60 of the American ones, and they're very well written, they're very short, they're pithy, and they're well researched.
Is there anything to be learned from the way the American program has gone about?
Transparency.
Yeah.
Very important. A focus. We've tried to get people to focus on their own specialties rather than picking on other areas, if that's a fair or unfair way of saying it. But as I said earlier, 29% of the recommendations related to cardiology. If that's probably unnecessary. So we would prefer that societies related to what they were doing. I mean, the gastroenterologists in America did it particularly well. They chose 3 of the things that they did that they thought could be done better. While the ENT surgeons didn't relate to any of their procedures.
Really?
And we hope that won't be reproduced in Australia. They had 3 X-rays that they thought shouldn't be done, and 2 antibiotic regimes that couldn't be done. Now, that's important in itself, and
yes,
very important that people should know those things, but we hope that it would be things that they do that, but on the other hand, you don't want it entirely what they do, because the College of Radiologists will only have 5 goes, and there'll be at least 5 that they can think of, if not 10. And I know they have guidelines for at least 15 procedures, so they'll probably perhaps want to be like the College of, and I'm not sure what they're called in America, but they're the equivalent of general practitioners. I think they might be called family physicians.
Yes, I think so.
And they put up 10.
Right.
Because they felt they had a large number that they could share with the patients.
Yeah. Is there a danger that the politicians will make the same mistake I just did and assume it was about cost saving and use this as a blueprint for cutting the hell out of the health system?
Well, no, because we're not going to sell it that way.
Yeah.
But that's not to say that what's being suggested may not have a financial impact. I mean, if we can stop people having unnecessary back X-rays, that will save money.
Yeah. And
will allow the health dollar to be spent on things that have got evidence.
Yeah.
But that's not the aim of the system. But as I said, you'd be naive to think that the payers aren't going to take notice of this, and but they're not going to stop people doing things. What they're going, if I were one of them,
yes,
I wouldn't be stopping people doing things. I would be saying, do it as the guidelines suggest it should be done.
Yeah.
you know, if the patient's back pain lasts more than 6 weeks, get an X-ray. But don't do it up until then unless there are red flags.
Yeah. Is this not a replication, but is there an overlap with the guidelines that colleges put out now anyway?
The guidelines the colleges put out, or international guidelines, everything, are very good, but they are not something that is digestible by the public.
Yeah, yeah.
You know, you've got to have quite an intense knowledge of the area to know what to do. So, no, I don't think. I think they're parallel and they have a synergy.
Yeah.
But you could probably look at these as the bottom, the outcome end of guidelines.
Right.
Rather than the whole flow through that, you know, if you've got this, you do that, and then you do that, and then you do that.
Yeah.
What we'd be doing is probably coming in at the bottom and saying, for this, you don't do that.
Yeah. Thank you for your time today.
Pleasure.